Doug is from the International Use of Force and Reducing Restrictive Intervention. He's a consultant in safe handling, and we're going to be talking about dealing with safeguarding taboos, but maybe safe restraining of people. And Doug is a specialist in the use of necessary force, and he's a professional trainer, particularly in soft restraining training and equipment. So without more to do, thank you, Doug.
Thank you. Okay, good afternoon, everyone. So I'm going to be taking you on a bit of a journey today through this safeguarding taboo that no one wants to speak about, and that's use of force. So I travel quite a lot, and I do a lot of work internationally with healthcare, community settings, policing, advising people on use of force, training to do things like PMVA and the use of mechanical restraint. So just before we start, I believe we've got one poll left, so I thought I'd take advantage of it and use it. So the poll that we've asked for is just about what people consider to be the least restrictive, because that's what we're all about, reducing restrictive practices. And people say, oh, is use of force to do with safeguarding? Yeah, use of force, human rights and safeguarding all go hand in hand together to do with the protection of people. So just a quick question, just to get a general consensus of the audience, what do you consider to be the least restrictive here? Mechanical restraint, seclusion, or manual restraint? So just a quick show of hands to check this is the right room. 50% who said, oh, are we still voting? Yeah, some people voting, some people not. Perfect. If you've not voted, have a quick look at this, and by the end of today's session, it's all over the place. I want to see if I can change some of your views. So I've come across colleagues before, and they've been in despair because they've been suspended from work, or they've been told that they've acted inappropriately, and they've said, I was told I had to safeguard the person. So I always say, well, what did your organisation expect you to do? When they say you should have safeguarded them, are they talking about containing them? Are they talking about restraining them? Are they talking about scaling this up and getting the police involved or getting somebody else involved? So I'm going to take you on a journey today through looking at health and safety legislation, looking at policy and procedures and some advice from government departments, and I've also got some great case studies. Some are personal ones from people I've worked with, and I've been allowed the opportunity to share with you some examples from within a secure setting from West London Mental Health Trust. Anyone from London here today? No? What's the point in having a north-south divide if you don't police it? So, first of all, use of force is dangerous. People get injured, people get traumatised by it. There isn't a safe form of restraint. You have lots of companies out there talking about their particular system or their particular product. Realistically, we want to avoid it. What we then get is organisations saying, restraint's dangerous, let's never do it. So they say, oh, we don't restrain. Well, if you restrict liberty, if you give instructions and rules, or if you ever put your hands on someone, you're using force. You're depriving people of liberty, you're taking away their rights. So it's something that there needs to be a policy on, there needs to be information, instruction, training and supervision given out to staff. Acts versus omissions. Acts are things that you do. Yep, you can be held liable for what you do and the repercussions of your actions, but omissions are the things that you fail to do. And everybody in safeguarding knows about omissions. So key issues around restraint. The idea of this presentation today is you can all take it away home with you. So there's quite a lot of it which is quite wordy. There's a few key principles in there which I'd invite you to explore if you're not 100% sure on them. So some of the basics around restraint. There's an element of risk for staff and the subject. Sometimes we're focused too much on the patient and these vulnerable people we speak of. Staff are at risk as well. We're talking about human rights. The absolute human rights we've got freedom of religious belief and things like that, but at the top we've got right to life, so your life has to be protected, and we've got the prohibition of torture. So I get asked a lot, oh, could restraint positions be torturous? Could it be deemed to be inhumane or degrading treatment? I'll tell you what's inhumane and degrading, going to work every day and getting assaulted. What about the staff's human rights? There has to be a balance here when we're putting together procedures. Certain restraints or positions are inherently more risky than others. We had a drive because of certain media representations to ban the prone position, which is the face down position. Now, I don't know about you, but I sleep in prone every night and I've not died once. So So it's not prone, is it? It's obviously other factors. It's things like weight, people sitting on top of somebody holding them there, prolonged struggling. There's a lot of different factors. And one of the things I saw when there was this discussion around whether we should ban prone restraint or not was organisations said, quick, come and train us how to restrain someone in supine. If you've suffered abuse, you don't want to be held in supine. In fact, prone might be the preferred position you go into. If you then get turned over by 4 or 5 members of staff who are struggling with you, that's going to be ultimately traumatic. It's going to re-traumatise you all over again. Certain groups are at higher risk, certain medications, certain conditions, BMIs, things like that, sickle cell anemia, all these things need to be taken into consideration. There's a clear ethical framework required, in my opinion, and Senny's law, which also known as the Use of Force Bill, the Mental Health Unit's Use of Force Bill, is great. It's a step in the right direction. But for me, it's about how people implement this, because what Senny's law does, in my opinion, is it takes the onus off the police from dealing with such emergencies, and it puts it on the units themselves and the trusts themselves. So never before has it been more important for people to understand the safeguarding implications, the human rights, and above all, the health and safety that's already in place. We've got a great health and safety framework in this country, and I'm going to show you today how it can be used to reduce incidents. Injury itself doesn't imply fault. I've seen this. I've seen people raise safeguardings because there's a bruise or a mark been left. Show me a restraint that doesn't leave a bruise or a mark. Show me a restraint where somebody isn't injured or somebody doesn't suffer some kind of harm. It's about proportionality, and we have to look at that sensibly when we consider how people are injured during restraints. There's a variation in the nature, the use, and the reporting of physical restraint. Hopefully, the new legislation we've got will help combat this. Pain compliance, which is one of these 2 taboo discussions we talk about, the prone position and mechanical restraint devices, they're controversial, but some organisations rely on them, and they couldn't do their job without doing this. And others say, we're never using it. We're not considering it because we don't like it. Nowhere within a health and safety framework does personal opinion come in. You've got to look at evidence, and you've got to look at how you've come to that decision. Internationally, which is why I've established the business I've got, teaching soft restraints abroad over the last few years, internationally, people are awake to this because I turn up at these establishments and they're fastening people to beds, they're fixing people in chairs, and they've got one person watching them. So for us, a set of Velcro handcuffs as opposed to a set of rigid cuffs, it just makes immediate sense to look for a less intrusive option for all available. There's been cases in the UK of deaths. The image I showed you on the front was an image from the protests after Eric Garner was killed in New York State. And the UK, again, Olusegun Lewis has died, and there's changes being made. It tends to be that a death has to happen for us to start making changes and learn from it. Just add to that Jimmy Mubenga, who died whilst he was being deported, and there's some valuable lessons that we can all learn from. This I've been given from West London Mental Health Trust. It's in its original form as the patients put it together, and I think it's a great perspective here of the different views of somebody who's been restrained. You've got the patient's experience, you've got the staff's experience, and you've got the experience of the people who are witnessing this. Now, this is from a secure unit, but this could easily transpire into any setting, anywhere, couldn't it? The public on the street watching it. Show me an arrest that's not on a smartphone. Everything now seems to be documented. We're doing quite a lot of work with cruise ships at the moment, training staff in how to de-escalate, how to detain people, and how to safely restrain them. And that's as a result of an incident that happened on the Carnival Legend cruise ship. If you haven't already Googled it, it's worth it. Yes, some of you are laughing. Carnival Legend cruise ship, somebody stood on the back of somebody's flip-flop, or thong, as they call them in Australia, but there's a problem with discussing that. The fight that ensued involved 40 people from 3 different families and went on for 3 days. How do we know about this? Because it was documented on mobile phones and it was put all over YouTube. So as a result of that exposure, changes are now happening. And you've got the person at the centre of it being restrained, but you've also got the other victims. You've got the people that are going to have to deal with their mental stresses after having to witness this or even physically do this to a person. So just going to health and safety, let's go back to this, because in the hierarchy of law, we've got human rights that sits at the top. It's an offence for an act in the United Kingdom to not comply with the Human Rights Act. I think that's Article 8. And below human rights, which is to do with protection of life, and liberties, you've got health and safety. So those are the two things you've got to make sure you've got right before we then start looking at the intricacies of perhaps guidance documents from the government or government departments. So it says you have to have in place competent people. How would you define competency? In health and safety law, it's knowledge and experience. So people that have done the job for 20 years, that's great. But if you don't continue your CPD, you can't be deemed as competent in the eyes of health and safety law. This isn't me having a go. On the other hand, you can be an academic, but if you've not stepped foot in those shoes or you don't know how it works, and you're turning up telling people that my book says you're doing your job wrong, you're not going to be very well received. Training and requirements for these people with specific responsibilities, things like layout of the premises in relation to escape routes, warning systems and emergency lighting, and equipment required for dealing with the emergency. What's equipment required for dealing with emergency? Could easily be a set of these. It could be soft restraints. When we look at things like first aid, we've got first aid kits. We've got resuscitation devices, AEDs, because they're not taboo. We talk about use of force or anything like this, nobody wants to discuss it because we think it's something that's over-restrictive. And communication with the emergency services. So we've already got something in place which is echoed in the new legislation. And it's a Memorandum of Understanding, that's the first time I've said that successfully this year, between the police and certain NHS units. And it's great because it talks in it, and it refers to NICE guidelines, NG10, which I'm going to talk about in a bit, authorised equipment, such as handcuffs and restraining belts. It also talks about the range of equipment that police have available. So recently, NHS Digital, I think it was, released some stats, and immediately the tabloids jumped all over it. And they were talking about, it's disgusting the amount of times that the police are restraining people and the use of taser. Don't forget, a use of taser is when it comes out the holster, doesn't automatically mean it's been fired. I think Norfolk police had 100 uses, and 3 of those were where it was actually fired. But tabloids don't let the facts get in the way of a good story, and they sort of run with it anyway. If we're saying to trusts and PQs, you can't use mechanical restraint, you can't use certain restraint methods, you can't hold people face down, and we're limiting the actual training that they get, they're not going to be able to deal with the emergencies. So who will they call? They call the police. And what do the police do? The police do police stuff. So they arrive, and they're forced to deal with somebody who's probably been struggling for a while, under the influence of drugs, possibly antipsychotics and things like that, probably overheating, they've probably got a history of trauma in the past. And their response, because they're so dangerous, might be to use a taser. It might be to use cuffs. Could this have been avoided if there'd been a better setup within the units? Possibly. So you'll see on the bottom there, the national decision-making models mentioned. There's 2 principles I want you to leave here with today. I'm a big believer on principles over techniques. You can teach people techniques all day long, but if you get some principles into their head, they can think for themselves. The national decision-making model, if you've not come across it before, does what it says on the tin. It's a nationally recognised way of making decisions. All police officers will be familiar with this, and it's a great way to implement this in your trust. Looking at things like gathering your information, doing your threat and risk assessments, considering where your powers end and where the police responsibility might then take over. Identifying your options and then taking action and making a decision from it. Something that you can bring all your other documents into, and it's a great way of taking the emotion out of criticising the way things are done at the moment. Because if you've got something to work from, it stops becoming a competition, it becomes something you can have a discussion about. So, health provider commitments. This is what the police expect from you guys. You should be doing clinical interventions. You should be taking fluids with or without consent. You should be doing the risk assessments. It's not the job of the police to turn up and mop up the mess. They should take steps that are reasonably practicable to safeguard other patients. So patient-on-patient assaults are something that sometimes goes unreported. Back to the original views, people witnessing restraint, that could be a safeguarding issue because of the trauma that they've been through. And restrictive interventions allied to psychiatric care. What does that mean? Well, it's these kind of things. Transfer of patients to a seclusion area or between A&E and units, administration of treatment without consent, maintaining observations, and retaking control of any restraint as soon as it's safe to do so. So I've dealt with trusts, and they've said, look, the police are saying to us, just because we have to administer the medication doesn't mean we should be coming to deal with this. Well, We understand things like breach of the peace, but this is a known risk. This is something that we know you're going to have to do. Why have you not got training in place to manage this risk with whichever level you need? The second principle I want to leave you with today, the first was the national decision-making model. The second is the hierarchy of risk control. Not the best name, so we've got a nickname for this in the industry, and it's known as Eric Prevents Death. Has anybody come across this before? This is great. So I use this to talk about reducing interventions, because the nature of my business is people ring me up and they say, we need you to train us in this. We need you to teach us a way to get from this position to that position. So one of the things I talked about on that last slide was access, getting in and getting out of places. The amount of organisations that ask me to teach them how to restrain someone and take that person up or down a flight of stairs is ridiculous. Now, I don't know about you, but sometimes when I'm at home, I often fall up the stairs. Does anyone else do that? So that's where I'm at home, where I'm happy, the heating's on, my heart rate's like that, and I can't even do it safely. Why would I try and risk assess me getting somebody down or up a flight of stairs? First question would be, if the building was built with the intention of it being an establishment, why have you not got lifts and why have you not got ramps? Because we've got things like disability discrimination. And the second thing is, can you not calm somebody down at the top or the bottom of the flight of stairs and then consider moving them? If your seclusion room is on floor 3, something's probably going wrong within your planning. So just for me to map this is great because it's an international premise. So when the first thing that happens, even if you go over the border to Scotland, people say, oh, sorry, criminal law, it doesn't apply to us. So you have to back away from the legislation of the UK and look at other ways to have these discussions. So this is great. First question is, do we need to restrain people? No? Then don't. Job done. Hang on, we've got a duty of care. We sometimes need to. Fine. What can you do to reduce these interventions happening in the first place? What are your antecedents? What are the triggers? What's the rapport like? Are staff empathetic towards the needs of the service user? We also reduce the risk of restraints by having adequate staffing levels. Again, companies, we need to learn some single-person restraints. Why? Well, that's all the staff we've got. It's called risk versus cost. You make sure you've got the correct staffing levels so you can manage accordingly. Control I've put in red. So control is the physical stuff. It's the holding, the restraining, the breakaway techniques that some of you have probably been involved with. Before you even consider doing a control measure, ask yourself this. Might it be better we back away and give this person a bit of space to calm down in, or might we be better containing the person rather than restraining them? Now, if I just flick forward a slide, one of the key points from NICE guidelines, it talks about avoiding seclusion, especially when someone enters an A&E unit and they're presented as having a mental health problem. So if we're not allowed to use seclusion, which is isolate, then what are we left with? We're left with the physical restraint, the holding of people. Well, holding's dangerous, and if the risk assessment says that it's too dangerous, you should be considering PPE. What's PPE? Personal protective equipment, or work equipment for that nature, which I'll talk about in a short while. D, what does discipline mean? Discipline means, and to quote Einstein, don't keep doing the same thing and expecting different results. If you've got somebody in seclusion, don't just leave them there and hope that they get better, because that doesn't happen. You've got to try and reintegrate them. You've got to try and look at getting them interacting with other people, playing cards, playing Xbox, getting them out of that. If it's not safe to do that, then we look at, right, what are the reduction measures? How's the medication going here? Or if you are at a loss as to how you're going to deal with this patient, it's the top one, which says the patient's in the wrong setting, maybe we should look at transferring them. Now, people say to me, oh, it's easy for you to say that, but people don't listen. Every organisation has got a person in charge of health and safety. Sometimes they even dress like those people there because they're so into health and safety. Day one of any health and you know them, clipboards. Any person who does health and safety, this is what they learn on day one, hierarchy of risk control. So say, this is how we're managing the situation currently. Can your health and safety person comment on our risk assessment? Are we doing everything we can to comply with the hierarchy of risk control? Because it's their job to make sure that happens. Now, I'm not guaranteeing this, but I've seen people take this away and get extra funding, get extra staff in, get money for training. One school I work with even had a building built because they'd been told they had to deal with this pupil because the special schools were full. So if they were going to deal with it, how does it fit in there? They had to have something in place to manage it. So just moving forward, let's talk about restraint. Restraint is a manual handling activity. People forget this. So if I'm going to pick up this imaginary box here, there's a ACOP, approved code of practice that tells me how to do this. But I don't need to talk to you about that because you all know what it is because it's what your mums and dads used to tell you. How do I pick this box up? Bend your knees, keep your back straight, yeah, keep the load close to your body, don't twist your trunk, feet face the same way as your shoulders. If you're male, don't attempt to lift more than 25 kilos, and if you're female, don't attempt to lift more than 18 kilos. The people you deal with, who represent themselves as patients, do they weigh more than 3.5 stone? So it's a manual handling activity. Let's break this down even further. So another job of mine is I work as an expert witness, or a consultant, should we say, and I'm employed by insurance companies who are paid, solicitors who are employed by insurance companies to write reports on things like injuries. And where people have been injured, restraining people, this is the main kind of stuff I cover. So the load they were asked to support. Now again, okay, we're personifying this person as an object, but this is what health and safety law tells us. A load can be a person, a patient, or an animal. Is it heavy, bulky, or unwieldy? Difficult to grasp, or if it doesn't want to be held, it absolutely will be. The individual capability of the people restraining. The more experience you get, the older you get, and the more injuries you carry. So we've got things like false knees, we've got pacemakers, we've got dislocated shoulders on the job, speaking from personal experience. And you're then trying to hold someone who's much bigger and much stronger than you. The task, excessive pushing or pulling, long distances, twisting, and what about the environment? I mean, all of that, you just wouldn't do that risk assessment and try it. You'd say, hang on, we need to go back to the drawing board. So if control measures aren't sufficient, what's the next step? Well, it's talking about equipment, isn't it? When we're talking about mechanical equipment, so again, we immediately look at handcuffs and we think, oh, that's disgusting, we shouldn't be using handcuffs. Who shops at Waitrose, Sainsbury's or Tesco's? Who shops at Aldi or Netto? Oh, cut the room in half. Look at that. So, when my wife's at home, we shop at Aldi and Netto because you get all your week shopping for about £20. But if I'm on my own, we have Booths. It's like Waitrose in Lytham where I live. So I'll go to Booths, and it's nice because I injured my shoulder over the summer. People help me pack my bags. I get these little green tokens to give to charity. I have a nice chat. It always smells of fresh bread, and nobody ever pings my car wherever I park, which is a hang-up from Aldi. If you go to Aldi, it's a completely different checkout experience, isn't it? So it's more like this, sprint packing, and they chuck it at you. Do you know why that is? It's because of work-related upper limb disorders and musculoskeletal disorders. American and European supermarkets, we're still paying out. We're still part of the compensation culture. But Scandinavian and German supermarkets have said, if you're twisting, if you're turning, and if you're lifting things, you're at risk of this. So you take regular breaks, you sit still, and you ask the customer if they've had a nice day, but you don't ever help them pack. You look at your shopping experience differently after today. So if supermarkets are taking those safeguards to stop injuries, why am I still seeing staff hanging on for dear life to people that are struggling, or told they're not allowed to restrain? Well, then when the person comes to attack them, what do they do? Just break away repeatedly? So on equipment, so again, when we talk about work equipment, this includes handcuffs, it includes soft restraints, it includes stretchers, it includes devices that can hold people. So the first test is, don't just say, oh, well, we've got this. This seatbelt on this wheelchair will do. No, the seatbelt on a wheelchair, what's it there for? Stopping people falling out. It's not to fix them in. If it was there to fix them in, it'd need more padding, it'd need to be medically risk assessed for that activity. It should be safe for use, maintained in a safe condition, and it should be inspected. Why might we have to inspect certain restraints? Certain restraint equipment we use to lift people. What regulations would we be looking at there? Correct, 10 points for you. Lifting of loads regulations, whichever country you're in. They should be used by people who've been trained to use it. So again, I'm a big believer, don't just leave this, oh, we bought this kit, let's put it on the ward. No, you've got to let people only have access to it who need to use it, who've been trained in its use. Should come with safety measures or a training package as well to make sure you can use it. Now, over the last few years, people have been hung up on this, and it's the NG10 guidance from NICE. And what it basically says in the bold print is it talks about mechanical restraint should only be used in high secure settings or from transport to from medium to high secure. Now, if we can just quote Eric Baskind on this, he was asked about what his view on this was, and he said, this can't be correct because we don't live in a Lego world where the nasty criminals are there, the people in the Lego school are there, and the people on the street are there. You know, these people that are in high secure, are they born there? They end up there somehow, so we deal with them, the police deal with them, the teachers deal with them, and then the people in the units deal with them. So it's not really sensible. So I looked into this, and people have constantly quoted this and said, we're not allowed to use this. Well, if you read the NICE guidelines, it reiterates that NICE aren't writing legislation, they're giving guidance. I don't know about you, but I got loads of guidance from my mum and dad. I listened to none of it. Some days I wish I'd listened to some of it. And the government departments, they're a bit like your mum and dad. They give you some advice. Some of it's a bit outdated because it's back from the time before. And I went to the NICE board meeting earlier this year, and one of the questions I raised was, if you're saying to people they can't use mechanical restraints, how do you evidence that they're using the least restrictive methods? Because mechanical restraints can be least restrictive. Seclusion can be less restrictive. What's less restrictive to you? Somebody hanging onto your arm as you try and break free from them, or somebody giving you an area to calm down in, or holding you with a device. You know, some circumstances and some settings, that will be more appropriate. And some people don't like to have hands on them. So if there's an alternative in the form of a piece of fabric, that might be more comforting for them. So we move on to this question, don't we? Because a lot of staff, we hear about this zero tolerance to incidents. For me, and I've seen this in the news yesterday, zero tolerance doesn't work because some people don't know where the line is, especially if their mental state isn't exactly how it would be normally for them. If they've suffered some kind of trauma in the past, those triggers, that amygdala that we spoke about before, that's going to kick in straight away. And also, if you've got special educational needs as a child, or you've got a learning difficulty or a disability, you might not be able to keep quiet. You might not be able to stop from putting your view forwards or using certain language that doesn't conform with the trust policy. And as a result, what happens then? They end up in more incidents where they're restrained. So just on this, about staff safety, Employment Rights Act 1996, Section 100, Section 110. I am a geek for this stuff. It says, you cannot be disciplined or dismissed for defending yourselves or others in circumstances of serious or imminent danger. And it also says you can leave or propose to leave the workplace if that danger is still there. And when we talk about things like knives and firearms, I mean, what's the police response to a knife? It's an armed response unit, isn't it? The police aren't going to try and take a knife from somebody by wrestling it out of their hand. They're going to arrive with the correct and necessary procedures to do so. So when I speak to organisations, they say, oh, we need some PPE. What for? So we can take knives off people. Oh, hang on a second. Let's take a step back here. Or how, again, people in the community, housing associations, or people visiting properties. They'll say, we need some of your training, some of your breakaway training. So really, tell me why as part of the training needs analysis. And they'll say, oh, we've got people that have been threatened with guns or they've had dogs set on them. I've got the simple solution to that. Stop sending them. Because wherever you're sending them, your risk assessment can't possibly be right for that. By giving them a stab vest or a bite-resistant arm guard, I'm not entirely sure. Because you know, if you've got a bite-resistant arm guard on, guess where I'm biting you? Anywhere except the arm guard. And also, when do you put this stuff on? That's what makes me laugh. Oh, great. When do we wear it all the time? So reasonable force in a nutshell. I don't want to spend too much time on this because you've probably heard this before. In order for a force to be reasonable, first of all, it has to be necessary. So you see, we tie that in with eliminate. We avoid it if we can at all costs. If it is necessary, why would force be necessary? Prevent harm to self, harm to others, or damage to property. Generally, that's what we'll be dealing with. The second test is proportionate. The best way to define proportionality is to say, if we did nothing right now and we watch this unfold, the injuries that were likely to be sustained by us doing nothing, if we intervene, have we caused equal or less harm? If you intervene and cause more harm, then it could be disproportionate, so it might be deemed not to be reasonable. Do we need to intervene? Yes, if we do, we're about causing a less amount of harm. So when people say to me, oh, cuffs and restraints, they're very restrictive, I guarantee that will cause a lot less injury than somebody struggling for 4 hours while staff hold them, trying not to loosen the grip and trying to deal with sweat and build up and the stress of being so close to somebody. Do we all remember this case? Yeah, excellent. So this happened down south not so long ago. This was a pensioner. It was all over the news because the Daily Mail love a good pensioner self-defense story. A guy came down in the middle of the night, was confronted with two burglars. There was a scuffle. He took the knife off him and he stabbed the man through, in the leg, I believe, and he bled to death. So this man was arrested. He was questioned by police, but he wasn't prosecuted. So why wasn't he prosecuted? We'll just take a little step back on this. Do you think he needed to do something? Absolutely. The harm he caused to the attacker, was it less or equal to the harm that he'd avoided? Potentially less, wasn't it? Now, unfortunately, because of the support for the burglar, this man was forced out of his own home as a result of that. But just looking at the Crown Prosecution Service, they've had guidelines in place since the day I left school, and they've stuck to them. And what they say on this is particular care must be taken where you're dealing with allegations that are made by a victim who's engaged in a criminal activity themselves. Would anybody in this room forcibly put their hands on another human unless you were trying to stop that person coming to harm themselves, harming somebody else, or damaging something? No. So in a nutshell, that's what we talked about before. And this is a criminal activity. So it goes in your favour. What it goes on to say is that where the use of force is reasonable, you have an absolute defence and charges should not be brought. What does reasonable mean? It means necessary and it means proportionate. And provided that's in place, that's the justification. Just to give you an idea on this, between up to 2005, because people say to me, oh, this is great, that pensioner getting off, it'll change the way the law works. The law hasn't changed. The law's been like this for ages. 20 million crimes were committed in the UK up to 2005 in the 15-year period before that. Out of those 20 million crimes, the amount of people charged with using excessive force stood at 11. Now, those 11, they were mainly homeowners who went too far in defending themselves. Let me just define for you what too far was by the CPS. One was where a burglar was found with 27 stab wounds in his back in the porch of a property. And the other was where a mechanic caught a burglar, wrapped him in a carpet and put him in the boot of his car. I haven't finished. Drove him 5 miles to work, put him in a pit, doused petrol on him, and tried to set fire to him. So we're not talking about a bruise here as you break a strangle from someone or when you're using some kind of a hold. These were serious incidents, and rightly so, the CPS, they are good on this stuff. So, back to this question that we talked about before. Can the use of mechanical restraint be the least restrictive option? Talk about mechanical restraint, it conjures up images like this. You look back to those films, One Flew Over the Cuckoo's Nest, and you think to yourself, oh, that's so outdated, the days of Bedlam and watching people who are mentally ill as some kind of attraction. We're never going back to that. We're stopping this kind of thing. And as a result, mechanical restraint has become taboo. You know, we never strap people down or fasten people to things like I've seen in Australia and other places. 5-point restraints holding people to beds in Mallorca in a trust we work with there. It's absolutely commonplace. They cancel family visits because it's so traumatic. So they then wait until they can get them out of the harness that they put them in. So this is a waist restraint belt. This is used by West London Mental Health Trust. It's similar to a product that we have, which is a safe holding system, which is basically a belt with cuffs attached to it. So if you've got someone who's in seclusion, and every time they come out of seclusion, they assault someone, the risk assessment might say, we can't do this. We haven't got the correct staff in. We can't risk injuries to staff. Well, you can't leave them in there because they're not going to get better. You've got to get them out eating food with other people, playing Xbox, playing cards, watching movies with people. So the waist restraint belt has allowed people to do this. Another example of mechanical restraint is the stretcher that's being exhibited by Nick at the back there. This has already saved a life in a PQ in the UK, and this is where somebody needed to urgently be transferred to hospital, but they were still struggling and they were still fighting. What do? Do we just say, oh, the risk of injuries to staff is too great? Or do we just wing it and say, let's just put them in the van and try and get them there? Because don't forget, this new legislation and guidance points at mental health units doing the transport as opposed to the police. So patient feedback of people who've been restrained, they talk about stopping them reacting to urges. It lets them attend meetings so they can talk and get their point across, because prior to that, it might be deemed not safe for them to go even by video link. Lets them play Xbox with other people, lets them feel safe and interact in meaningful activities. Yes, 2 minutes, perfect. Patients observing their peers. They say they feel safe when they're out of it. Scared at first, but they can spend more time out with their friends. And it's nice to do something different rather than being stuck in seclusion all the time. Staff feedback, user-friendly. They're happier because they're not having to hang on to people for long periods of time. They're less likely to be assaulted. You know, how much empathy can you have whilst you're hanging on to someone, trying not to get bitten, trying to focus on these skills to defend yourself? And from a visit to the PQ by the CQC, the patients gave their direct feedback to the CQC inspectors, saying they were happy to be in the belt, gave them opportunities. Before they were using the belt, they wouldn't have been able to do this, as I would have attacked you. And they were unable to talk to staff about voices that they hear. Again, you know, these are real life examples, and I'm thankful that we can actually share these today. So in Australia, we had a young lady who refused to come out of seclusion. Wouldn't happen. She'd been in seclusion for 12 months. Every time they took her out of seclusion, she was violent. We used this safe holding system as an alternative. So we said, look, if you want to come out of seclusion, we can do it. Just wear this. It allowed her to come out and feel safe. There was one incident where she was having a hearing and she became opportunistic and she managed to break free. And staff said she'd asked them to loosen the restraint and it had been a trick so that she could assault them. No staff were assaulted because there was a concentric circle of protection between them and the patient. Had she not been wearing that belt, the injuries would have been as they had been 12 months ago. So they're a good way of rehabilitating, any form of soft restraint is, to get somebody out of seclusion, get them back into doing meaningful activities. Supine, there was an incident in the UK, somebody had taken psychotropic drugs, and they were not calming down, they were causing harm to themselves and other people around them. So we used the soft restraint belts to hold the person in. Rather than being held on his back constantly for days on end, it allowed him to access fresh air. Again, the staff felt safer because there was that extra level. Okay, they might be able to punch or throw a headbutt, but it's far less restrictive for them than previously. Any questions?
Thank you, Doug. I'm going to stand over here. And I don't need restraining. Am I okay?
Not mechanically either.
Thank you. Thank you very much. And there was a moment in there when you got those handcuffs out that you were going to make me volunteer to be restrained.
That's wishful thinking, that's what that was.
Yeah, no, it's not Friday night.
The results of our polling, if we could look at that.
Yeah.
So what do we consider to be least restrictive? A lot of people say seclusion is least restrictive. Holding is least restrictive, mechanical restraint. And anyone change their views on that? Because seclusion works in some time. You know, when I was a kid, send me to my bedroom, let me calm down. I'm all for that. But keep me in there for days on end, posting food through to me. You know, there comes a time where we have to say, let's get these people better. Let's get them doing meaningful activities. That, for me, is the buzzword on that. The manual restraint side of things does cause injury. And obviously, mechanical restraint there are times for it. I think overuse of it and unregulation of it would be dangerous in the same way as a seclusion.
Yeah, so apply the most appropriate for the setting.
Exactly, it's tools in the toolbox.
Yeah. Great, thank you. While we're loading up questions from Slido, any questions from the floor? Like, where'd you get the handcuffs from?
See us at the back.
So thank you very much.
Thank you. I'll take these with me.
Yeah, thank you. Thanks,